Hi, and thanks very much for inviting me. For those of you who don't know me, my name's Trina Ritchie. I'm trained as a GP, but for the last 10 years I've predominantly worked for addiction services. For those of you who do know me, you know that I'm always keen to get a chance to say my bit from my soapbox. I've got very plain slides, I'm afraid, no pictures or anything, and not very many slides, because I was hoping to say a bit about pain and addiction from an addiction perspective, but really have time for discussion and questions. And please, I'm happy to take questions as we're going along. This is just a bit of a repeat and slightly different, I'm afraid, figures than Colin was speaking to. But just at that, Colin said 18% of the UK population have persistent pain, and with that compares to between 1/3 and 1/2 of treated substance misusers who will describe having persistent pain. I was just trying to put some figures around sort of how many people that is. So in Glasgow, in opiate substitute treatment at the moment, there's approximately 6,000 people, and there's just under 10,000 people within the health board area. So in Glasgow, that would be 2,000 to 3,000 people in opiate substitute treatment would have persistent pain, and obviously that for the health board area would be 3,000 to 5,000 people. So it's a lot of individuals. 1 in 4 people who are opiate dependent will say that they became opiate dependent because of pain. However, if you do it the other way around and look at people who are in treatment for opiate dependence and who have coexisting pain, you find that when you go back in people's history, the opiate dependency most often precedes the chronic pain. And again, a bit of an overlap with Colin, just really in trying to sort of summarise and put some structure around what I was going to say this evening, is just revisiting guidelines and just maybe to draw especially the last one to people's attention if they haven't seen it. Just was out in July 2013. So these are, most of these are joint guidelines, British Pain Society along with Royal Colleges. Pain and Addiction 2013 isn't a guideline, it was a consensus statement that came out with sign-in from buy-in from many organisations. The management of persistent pain in secure environments is, I think, very interesting in that obviously people who are within secure environments also come out and spend time in primary care, but it comments not just on opioids, that a lot of the other guidelines are quite focused on around pain, but around the other medications that are being prescribed for pain and some of the issues with that. This was the most useful way that I could think to try and break down the people with addiction into groups of ways of thinking about their management or their issues, not in any particular order, maybe sort of easiest to deal with first. But the main issue really around this for me is the lack of reliable data and the lack of good quality evidence. Many of the guidelines or much of the content of the guidelines from the last slide is based really on expert opinion rather than facts and reliable data. Alex Baldacchino at the University of Dundee Centre for Addiction Research and Education Studies undertook some work relatively recently for this group of patients who they call people with a history of substance abuse, history including current use. And what they did was did some qualitative work looking at the attitudes of physicians around prescribing and managing chronic pain and prescribing opioids to that population of patients, which is quite nice because I think it showed through interviews and focus groups what many of us think happens, that people say they're resistant to prescribing, that they feel unsure about people having genuine pain, and that they are concerned around various aberrant behaviours, early requests for repeat medication, opioids being the only thing that will help, hoarding of medication that we were just talking about, and diversion of medication. So I think that was an interesting piece of work really around attitudes. I would like to just go through these different groups just very basically. I meant to say at the beginning that I hope that nobody was looking for any answers from me, because I think I'm probably here just to underline the problems from an addiction point of view. The currently opiate dependent and using illicit opiate person in pain, we think is one of the most straightforward people, at least to begin to manage, because that person obviously needs to be in opiate substitute treatment. So people who are illicit users with pain, our treatment plan is to ideally stop their pain medication and start them on opiate substitute treatment. It's easier said than done because many people are not very keen to stop their pain medication, but that's sort of quite straightforward. That would be our ideal situation. People who are recovering or abstinent, again, I feel like I'm standing here saying things that everybody knows, but many patients who are now abstinent from opiates would prefer not just to not have any opioids prescribed, but we'd prefer to not have any medication prescribed. And we all are aware of and wary of the risk of reinstatement of dependence in prescribing opioids. But also, I suppose, something which I, on reflection, hadn't really thought that much about, around the distress of untreated pain being as much of a risk. Is it as much of a risk as reinstating dependence? Obviously, as Colin was talking about, the limited efficacy of opioids, and in particular in this population, we would be keen that they're not treated with opioids. Non-pharmacological treatments is something that, working in the addiction field, we're very familiar with. Non-pharmacological treatments, and something that we spend a lot of time trying to encourage individuals to engage with. For example, community benzodiazepine detoxes that we don't prescribe, and instead encourage people to reduce and stop their illicit benzodiazepines while engaging in a variety of non-pharmacological treatments that we have access to for addiction. And there's obviously an overlap with that, with what would be useful. Some of them would be useful for people with pain. I've said caution with non-opioid treatment as well in this population. I'll come back to the non-opioid treatment. And so the population of people who are in substitute treatment, again, we'll all be familiar with this, that a daily dose of methadone or buprenorphine will not provide pain relief for these people. The main challenges that we think of are with drug interactions of prescribing for these people, prescribing for pain in people who are on methadone or buprenorphine, and conflicting management plans in our time of recovery, where everybody is moving forward in their recovery journey, whether that is still within maintenance treatment or towards detox and abstinence. Introducing strong medication, whether it's opioid based or not, is quite a significant conflict with a methadone detox, a buprenorphine detox, and that causes us a lot of issues. It's interesting to see the average methadone dose of 65 milligrams daily. That's very much in keeping with the service average for the health board, and both within specialist services and shared care. And we have an ongoing debate at this point, usually when we're talking about average doses within specialist service. We don't have a way at the moment of pressing a button and separating out our titrating population, our maintenance population, and our detoxing population. So average doses encompass all of that. However, although people do detox out and leave treatment, the majority of people it's quite a stable population. People are mostly in maintenance treatment, and an average dose of 65 or 63 milligrams a day is only just touching into the therapeutic range. So for methadone, the therapeutic range would be between 60 and 120 milligrams daily, meaning that your average dose, if the majority of your patients are in maintenance treatment, should be between 80 to 90 milligrams daily. And it was nice to see that at least some of the patients who were on quite a few medications were on 90 milligrams or above. But that would be the first thing that we would look at for somebody, or ideally look at for someone with chronic pain. An option of splitting methadone or buprenorphine into 3 times daily or 4 times daily dosing gives much better pain relief. However, given that we are very keen on supervising most people's doses and reducing diversion, that can be a challenge. And I suppose one of the things that I wanted to say really is around that there is no one-size-fits-all answer, as we know, for people with pain, and that the options really very much depend on the individual patient and where they are, what their issues are. You may have someone that has very bad pain and reduced mobility, and not necessarily because of their stability from an addiction point of view, but because of their reduced mobility is on weekly dispense of their methadone or buprenorphine anyway, in which case they can split their dose because they have their medication at home. Opioid-related hyperanalgesia, so sort of well-documented dose-dependent lowering of the pain threshold. I'm afraid I don't know any recent stuff about this. I remember being at conferences when I first worked in addictions and have people over from Australia to Glasgow talking about studies where they had people immersing their arms in buckets of freezing water for different lengths of time and stuff. But something for us to be aware of, obviously, that the OST and other prescribed opioids could be worsening pain. Drug screening, the prescribing of opioids on top of methadone or buprenorphine can cause us some issues around our drug screening. Drug screening is part of a overall assessment, obviously, for addiction treatment, but it's very difficult to tease out the differences between different prescribed opioids. We have been quite keen on tramadol for that reason, because it doesn't screen opiate positive on our near patient testing. However, I'll talk about tramadol in a wee minute, but that is can be preferable for us in some situations because we can continue to screen people. And again, caution with non-opioid treatments. So dependence on painkillers, this huge problem in the United States. Bits and pieces of data in the United Kingdom around about this, but as we've been discussing earlier and with the pharmacy data, there's not thought to be the same size of problem, but not the same way of gathering information. Over the last 5 years, there's been an increase in tramadol deaths, both within the health board area and within the UK, and an increase in prescribing. I have some of the figures for some of the other drugs. I'm afraid I don't have the figures for the tramadol. In the Global Drug Survey last year, they asked about tramadol use for the first time, and they described, I think it's 364 people who said that they'd used tramadol. 1 in 5 of those had tramadol prescribed for them. So 4 out of 5 had sourced it from, mostly from friends. And they described a variety of reasons that they took it: to relieve boredom, for pain, to get high. So we're really seeing that coming through as a drug of abuse, although I'm also saying that we find it more useful because we can, because it doesn't screen for us. Yeah, so I said I'd come back to the non-opioid management. It was interesting going back for me and reading some of the guidelines and thinking about what I was going to say and just how focused the guidelines were on prescribing opioids, because for us, although obviously it is an issue for the people who we see, some of these other prescriptions are really causing us as much, or if not more, anxiety at the moment. You can imagine that, although I said I just illustrate the breadth of people who we see, obviously we see a lot of people who are on opiate substitute treatment, who are Hep C positive, who potentially have liver damage through alcohol as well as their hepatitis C, and who are already processing methadone on a maintenance dose. So non-steroidals can be a non-starter in that population if they have alcohol complications, or they're smokers, they maybe don't eat well, and to add in paracetamol to the woes of their liver processing isn't going to do them any favours. Tricyclic antidepressants and anticonvulsants, and that's what we're all left with as sort of potential prescribing. I was having IT problems to get a data source on the bottom of that, or a description of what it was. So these are Greater Glasgow and Clyde, these are Health Board drug-related deaths which involve amitriptyline over the last 6 years, with implied being, as you know, directly implied in the cause of death, and present being present in the body at the time of death. I don't have a breakdown of how much of this was prescribed or not prescribed, but you can see that, especially in the last 2 years, we have, do my maths, really quite significant numbers of drug-related deaths involving amitriptyline. And my last sort of illustration of patients that I just wanted to share was a cluster of patients. So in July last year, during the Glasgow Fair, unfortunately I was providing sort of senior clinical cover for Glasgow Addiction Services, and these things always happen when your colleagues are on holiday. Got a phone call from the police superintendent at the STOP unit, the Statement of Opinion unit, which takes to do with drugs strategy or opinion, and they analyse tablets and have intelligence around what's going on, asking for advice about putting out information, because they were very worried that there was contaminated heroin in the Glasgow area, that they had a cluster of near-miss overdoses reported to them from the A&E staff at Glasgow Royal Infirmary, who had four near-miss overdoses, 2 of whom required ventilated in the last 48-hour period. In fact, it happened that one of those people wasn't in the cluster, but so it ended up being 3 individuals who were all unconscious, near-miss overdose, and on screening they all had methadone, opiates, benzodiazepines and tricyclic antidepressants, in fact amitriptyline, in their drug screen. But that they had come from 3 different places in Glasgow. 2 of them had been brought in by ambulance. One person had been brought in by a friend to Glasgow Royal Infirmary and deteriorated. The 2 people who had been brought in by ambulance, one person had been brought in from a house in Possil, and one person had collapsed on Maryhill Road in sort of Ruckhill part of McDonald's on Maryhill Road. And very concerned that this was going to suddenly escalate and be many more cases, but that they hadn't had any intelligence of contaminated heroin. Heroin contaminated with tricyclic antidepressants is more a red colour. There had been, I think the year before in the Ayrshire area, there had been contaminated heroin, and really sort of looking for some advice about what to do, which I didn't feel able to give, so I thought, well, we'll try and find out a bit more about these people. And there was a 47-year-old lady, a 43-year-old male and a 28-year-old male, 2 of whom were prescribed for in shared care and 1 of whom was prescribed for in the CAT. They were all on methadone. The 47-year-old lady was also prescribed mirtazapine. The 43-year-old man was prescribed amitriptyline. 56 tablets at a time, dispense weekly prescribing. And the 28-year-old man was prescribed amitriptyline, 112 tablets on a prescription, no instalment dispensing, and it turned out had 2 repeat prescriptions in the month before this and 1 repeat prescription already in July, so had amassed a quantity of tablets. And the police were able to track that all 3 of these people had spent time within the 24-hour period before in one address in the house in the Postle area, and had been taking heroin, taking benzodiazepines, and had shared out and taken a quantity of amitriptyline between the 3 of them. So there wasn't a need for any public health and contaminated heroin warning, but obviously it was a concern around their stockpiling, hoarding of amitriptyline, sharing it out, taking it recreationally, and with 2 of them being ventilated, obviously they were very lucky that all 3 of them were still around. So that's just another illustration of maybe our concerns around some prescribing around pain. And so these are the same figures for gabapentin and pregabalin. Yes, so again, I'm afraid I was struggling. So the left hand implied and present is gabapentin, and the right hand implied and present is pregabalin. For anybody who's really on the ball, you'll notice, actually, I should have said this in the last slide, that the total deaths, so this is Greater Glasgow and Clyde drug deaths, if you're comparing that with figures that come out from like the NROS, these are slightly different figures. We have a drug death research associate who looks at people who actually died in that year, as opposed to the NRS who look at registrations for the year. There may be some delay and stuff. So just in case you're looking at these figures and I think they're different. But again, just seeing an increase in, not big numbers obviously, but just, you know, things that weren't there before that are now implied in the cause of death. Gabapentin, 9 out of 163 deaths. And this is PRISM's data. This is for all of Scotland, and this is, my pharmacy colleagues can help now, daily divided doses per 1,000 patients, would that be right? So it's not really the overall numbers for me, I'm afraid, in daily divided doses are, you know, not something that I spend a lot of time dealing with, but just really looking at the increase. So Scotland-wide, daily divided doses per 1,000 patients, and the doubling of prescribing of gabapentin and more than 3 times prescribing of pregabalin. Yeah, so not a huge street value, gabapentin and pregabalin. Looking at between £5 and £8 for an 8 milligram Suboxone tablet, illicit street value. Gabapentin and pregabalin, maybe around sort of how they're taken, tend to be taken in large quantities. So people describe a dissociative euphoria taken once in a day or whatever frequency that you're going to misuse them on, but in larger than prescribed doses. And people tend to buy the quantity on someone's prescription. So if someone gets a monthly amount of gabapentin, then they would sell that for around about £10. And I suppose really, I was just putting that in there, you know, is there evidence to support prescribing of these things and the increase in prescribing that we're seeing? I noticed that, as Colin said, there's lots of interest in this area, and because I was having a look at this, I saw that there's huge amounts of toing and froing in the BMJ over the last few months and in the rapid responses. And I see that Des Spence last week, I think, had something about gabapentin and pregabalin, and pointing out the NICE guidelines and the support of these medications, that the longest trial was 13 weeks long. I'm afraid I haven't gone and looked that and checked that for accuracy, but 13 weeks doesn't seem very long. Patient-centred individualised care, so as I said, one size doesn't fit all. This comprehensive assessment of pain and substance misuse, including drug screening. So if many people who are describing chronic pain haven't already established opioid dependency, especially people who may not want to come into regular opiate substitute treatment for a variety of reasons, who are looking for opioid prescribing. And risk management. All I've illustrated is problems in this patient group and no solutions. So I suppose my way of thinking about it is that if you and the patient are aware of potential issues, potential benefits and harms in the context of reflecting on sort of current evidence, what there is, making a decision, acknowledging the risks, the benefits and the harms, discussing it and documenting it, I feel is the way forward on an individual patient basis. And communication that we've already talked about, it's very difficult working in a bubble. Addiction services have become slightly better at sharing information out the way. They still have a long way to go. There's very little information that comes in the way to addiction services either. There's a new template letter for the community doctors in addiction services to fill out that was developed with some feedback from GPs in the Glasgow City area, which includes various standard fields. And it also includes at the bottom a sentence that says, please could you let us know if you're thinking about starting any opioids, gabapentin, pregabalin, benzodiazepines for this patient, because we don't have a system to be able to see that information, and I guess to raise the idea or the concern around it. That was all I really had picked out to say. I'm happy to take lots of questions.